So our plan is to have this seminar series run monthly via Teams, so an entirely virtual event to ensure that people can attend. We are planning to alternate the seminars between Mondays and Thursdays, and this is to include people who may have different working patterns, who may work in the middle of the week or who may work part-time, and the timing of the event will depend on the availability of the speaker, but we will let you know about these ahead of time. All of the events will be recorded as long as the speaker is agreeable, and they will be available on our Precision Health website, which is available at the link shown on the screen. We have a mailing list for people interested in keeping up to date with the seminar series. You can sign up at the link below or use the QR code. People who are external to Queen Mary from Barts Health Trust, please, if you email myself, I'll be able to add you to the list. And also, we'd be delighted to hear from colleagues about whether presenting their own work or suggesting presenters from people they work with or people they know. We'd be delighted to add you to the roster. And in that spirit, we've already begun planning the seminar series for this coming year with the organizing committee drawn from colleagues across the Wilson Institute and the Barts Cancer Institute. So these are all our chairs and co-chairs representing different parts of the institutes, and we'd be delighted if you wanted to join us in organizing. We've made a great start and already put together a list of speakers, many of whom have already committed to some dates. So these are some of our future seminars we have coming up. Next month, we're very excited to launch the Queen Mary Multi-Study License for the Clinical Practice Research Data Link. We'll have an introduction from Professor Fiona Walter, some discussion about what the CPRD license entails from our team and how to get involved using it. In December, we have a presentation from Hannah Brewer at Imperial about the Cancer Loyalty Card study. In January, we have a presentation from a colleague at the Karolinska Institute with more details to be circulated soon. And in February, we have a presentation on myocardial infarction event rates across England. And coming up later this year, we'll also have a showcase from our early career researchers and students at Queen Mary talking about some of their health data science projects. So that's all from me. I will hand over to Jianhua, who will give the substantive presentation, and we'll have questions at the end facilitated by our co-organizers, Harriet Larvin and Paris Baptiste. So thank you all very much.
Thank you very much for the introduction, Rohini, again. And thank you all for joining in this afternoon. I know some of you are probably still in the half term. Appreciate that you take time to join this seminar. I'm just honored to give this first talk in this seminar series. So I'm going to share some of my experience and the work about developing an AI-based algorithm to predict atrial fibrillation in general practice. So I think some of you may not know me. I'm Jianhua Wu. I'm a professor of biostatistics and health data science. I joined Queen Mary in January this year as a part of the precision medicine program. So the problem that I'm going to talk about is about the atrial fibrillation. It is a heart condition that often generate like irregular heart rate and often very rapid heart rate. And it's a very common abnormal heart rate and affect a huge amount of people across the world, about 36 million and about 1.2 million in the UK alone. That's give about 2% prevalence overall. If left untreated, atrial fibrillation will cause a blood clot in the heart over time, and hence that increase the risk of stroke by about 5 times compared to those without atrial fibrillation. If patient got atrial fibrillation and get treated with oral anticoagulant, then this can reduce the risk by 2/3. Over the past 20 years, I think the new cases of atrial fibrillation has increased about 70%. And it's just the amount to like similar to 4 most common cancers combined overall in the UK. But at time, because of the nature of the atrial fibrillation, some people got like the more on and off episode. It's called the paroxysmal AF, which can last about 48 hours, and then it can be become normal. So in those cases, it's very difficult to detect those AF cases, and about 30% of those AF cases in the community is undiagnosed. And that causes about 25% of the stroke, about 15,000 in the UK every year. There's some current approaches to detect AF, but they are not very good compared to just the routine care. For example, you can take the opportunistic post-palpation at health check, which from the report in the South Tyneside, there's only about 44% of those who are eligible attended the health check. And also across the countries and internationally, there are other schemes going on, like opportunistic check, along with the blood pressure check in the community care. But those studies also suggest that this doesn't improve the detection of AF over time, but that is probably because the nature of the AF, a good proportion of those are just on and off paroxysmal AF. And the early detection of AF is currently a cardiovascular priorities in the NHS long-term plan and recommended by the European Society of Cardiology guideline. So that's where we aim to try to provide a solution that can be used accurately to identify people for targeted investigation of AF using the routinely collected data that can be used at scale. So the current evidence for AF screening, there are two common approach. One is that I just mentioned, the opportunistic screening. There are two typical randomized control trial, which conducted one in the US and one in the Netherlands. And they both prove that there's no increase in AF detection compared to the routine care. Another approach is systematic screening, which targeting those populations who are more likely to develop AF. For example, the stroke stop, which conducted in Sweden, there are two versions of this randomized control trial. One is focusing on the people aged 75 to 76 years, and all the people being allocated with in the intervention group, people are allocated with the Xenical ECG handheld device that they can use easily, and will measure twice a day over a year. And the detection rate is only about 3%. And on top of that, they also added in the NT-proBNP, which is a biomarker that is commonly used for diagnosis of like heart failure. And that increased the detection rate slightly more to 4.4%. And a recent, well, not very recent study conducted in Wales, just looking at those age 65 and above, and in combination with Charles-Vask score, which is a risk score for stroke. And they use the AliveCore, which is another device that's to measure the ECG, can be easily used as a handheld device. And that's they report a similar detection rate as in the Sweden study. Another type of study that they use a continuous rhythm monitoring, that they use the device that can be patched to the chest for a period of time. For example, in this study, they use like for 2 weeks or 4 weeks in either of the mSToPS trial or the Screen AF trial. But their detection rate is also similar to the serial rhythm monitoring. In the loop study, which they use the implantable loop recorder over 5 years, So they have a device that be implanted to your chest and that can be stay on for a long time. So the detection rate is about 31%. But be aware that because the duration of follow-up is much longer compared to the other study, hence the detection rate is much higher. There's an alternative approach which they use the risk stratification of the participant. They give the participant a device to record their ECG over 30 days, and they use an AI to analyze this ECG signals. And in combination with a range of risk factors for cardiovascular disease, they stratify the patient into a few categories, like the higher or lower risk of developing AF. By doing that, they follow up the patient over 10 months, and in those higher risk intervention group, the detection rate is considerably higher than those high risk group which just going through the usual care. But still, whether those approach is scalable to a larger population, meaning that all the people will be given the device to measure the ECG, which is in dot. So we take a few approaches. That first we look at the current available algorithm that being developed to screen the AF risk. There are about 9 algorithms at the moment that are being developed in the community-based electronic health record, but most of them have a lot of shortfalls. For example, the moderate discriminative performance, which I'm going to show you in the next slide. And all of those algorithms use the non-prediction windows. For example, they predict 5-year or 10-year AF risk instead of short-term. And all the EHRs, they come from either the community electronic health record or from those longitudinal cohort coming from different population, disease incidents, and they have different comorbidities due to those restrictions. And also many of those algorithms use the data variables that are commonly missing in the routinely collected electronic health record. For example, the ChargeAF or Pulse AI, which are quite wide known in AF predictions, but they can only apply to about 17% or 35% of the community participant, because they use some of the variables such as the recorded ECGs, which is not available in the general practice. So as I said, those are the meta-analysis that we did to combine the risk prediction algorithms used currently available. The highest, I think, one of those is like 78, 79%, 0.789 in their say statistic. So what I mentioned at the beginning we want to do is really try to find a solution that can be applied to the community settings at scale. We come up with the idea of looking at the general population, which we use the CPRD data. Which I think at the beginning, Rohini already mentioned that we at the QM we will have the multi-study license. So do tune in a couple of weeks' time to know about more how you can access it as a to facilitate and help your study. So CPRD is basically a community, routinely collected health record covering about 7% of the general practice in England and Wales, and it being data has been in very good quality and being linked to a range of the other health records such as HES, ONS, and some cancer registry and different registries. They like the mother baby data you can also get. So the data we use is between 1998 and 2018, and we choose those participants who are aged 30 and over because AF incidence is extremely low for the younger people. And we exclude any of those participants who already have been diagnosed with AF at the entry. And those participants will have at least 1 year of follow-up from entry as well. So if you look at the table on the right-hand side, is that we have about 2 million participants who are eligible to be included. And compared to those people with no atrial fibrillation or the incident AF at 6 months, it is quite obvious that AF patients are more comorbid and elder because the average age at the diagnosis is about 74 years old, and the general population in this the age of those healthy non-AF cohort is about 50 years old, and the proportion of those comorbidities are much higher among the AF group. What we did first is we look at the AF incidence and patterns among the in this general population, and then we found that really the incidence has increased over the past 20 years by 70%. I think that is probably first compounded by the aging population, and also the comorbidity of the general population is also increasing, which I'm going to show you in the next slide. And there's quite a distinct difference between the male and the female, because as you can see that they in general for the men, they have much higher AF incidence compared to women. So there's inequality in developing AF, either by the genetics or other like the lifestyle and other social demographic factors. As I mentioned, that the comorbidity is also increasing quite significantly over the years. That probably contribute to the increase of incidence of AF. So you can see that the number of comorbidities has increasing from 1998 to 2017 in this graph, and overall it just keep increasing, and those people with 0 or 1 comorbidities are just decreasing quite a lot. And on the right hand side is just the individual, the trend of the individual conditions. For example, the diabetes has been increasing over the years as well. So what we want to do with those the initial investigation of the data is trying to understand the incidence and the patterns of the of this group of patient. So we developed a range of models, including the machine learning algorithms, to predict AF. So we get funding from British Heart Foundation, and with the acronym of FIND-AF, it's short for the Future Innovation in Novel Detection of Atrial Fibrillation. So we developed both like the statistical, the multivariable logistic models, as well as the machine learning algorithms. But the reason we choose the random forest because it is simpler and easy to implement. We also considered some more complex machine learning algorithms like the deep learning, the recurrent neural network. But after we discuss with the practical implementations with the like the software providers, it's turned out to be much harder to implement. So hence we opt for the simpler algorithm. So we divided the our population into a training set and a test set. The input to the model we limited to the age, sex, and diagnosis, ethnicity. So for the diagnosis, we extract from like the read code SLOMAD ICD 10 online in the previous version. And we included about 72 conditions overall. The output, the prediction is that we want to predict the individual level of risk of AF diagnosis in the 6 months time window, and later we extend that into different time window. I think one of the limitations that we encounter is that all the diagnoses we have are based on the routinely diagnosed cases. So we made the assumption that it's the positive response, that meaning that only those diagnoses being recorded in the routinely in the routine care are included, and we assume those who didn't have no such conditions. As you can see from this graph, is that we develop the model, and then and we can classify the each individuals based on their characteristics, the input features, and then we can classify them into the higher risk or lower risk of developing AF. So we use the area under the ROC curve to measure the prediction performance of our algorithm, and then compare to the multilinear multivariable logistic regression, and also a couple of the other commonly used risk scores like the Chas-Vasc score and the CHESS score. So our algorithm performs better overall compared to the other risk scores. We also looked at quite a few subcategories, how the algorithm performs, for example, in the men and the women, and also in different ethnicities. Some of the ethnicities that perform worse, either maybe there's some inequality, or there are not enough data in some of the subcategories, like the South Asian population, which are in smaller number in the CPRD. So we also conducted some clinical utility analysis using our algorithm. First of all, we want to stress that the utility of the Find AF is it's 100% applicable to the primary care electronic health record, because what we intend to do is that it can be applied to everyone. So we excluded those variables that have much larger missing values in there. So compared to like the commonly used algorithm POS AI, EHR AF, Charge AF, which are only applicable to a proportion of the participant in the community setting. And we conducted net benefit analysis compared to the commonly used risk scores, and also the net reclassification improvement compared to Find AF with Chas-Vasc and CHEST scores. So our algorithm shows better improvement in terms of the accurately reclassify those patients into the right diagnosis. In addition to that, we also look at the clinical outcomes by the predicted risk score. So we look at we stratified the participant by their predicted higher or lower AF risk, and then we look at about 10 major cardiometabolic outcomes over time. As you can tell, that a majority of those have a very good stratification in terms of predicting those outcomes using the higher or lower risk classification. And then we apply not just to the 6 months predictions, we extend that to 1 year, 2 year, 5 years, or 10 years. And you can tell that, over time, the longer the period, the prediction windows, the less accurate. I think that's understandable because, the input we have is about like 10 years old. So that's where the prediction performance dropped quite significantly in certain cases. One of the our purpose of developing the Find AF really is trying to implement that in the clinical setting. So that is where we want to both validate internally as well as doing that externally. So we have collaborated with colleagues from Israel, Brazil, and Taiwan, trying to validate our algorithm in their respective population. And by transferring our algorithm output, and they can directly use if they can extract all of the relevant prediction variables from their own database. So that we're in process of doing that. So we haven't got any result on that yet. So as I said, that we want to also internally validate our algorithm in a clinical setting. So we have designed this prospective interventional non-randomized pilot study, which we want to use the Find AF as a risk stratification tool to classify the participant into a higher and lower risk. And then we invite them to participate in the study. And then we allocate a ECG monitoring device for them to use at home over 6 months period. And the device then we analyze the device to identify whether the patient has developed AF within that time period or not. And we also have a risk matched cohort and just follow them up using the routine care without any intervention. So we are currently implementing this pilot study in the West Yorkshire. So we just started this quarter at the primary care in the general practice, and we included areas of different deprivation and including the higher ethnic diversities, like in the Bradford area, which will have very high proportion of the South Asian population. We intend to recruit about 2,000 people, and then we use the Find AF algorithm to classify them into higher and lower risk. The primary outcome is really just the diagnosis of AF using the ECG monitoring, and we will compare the performance of the algorithm because we have the gold standard of whether the patient will develop AF using the device monitor. So we work with a range of partner and stakeholders, both nationally, regionally, and also the primary care partners. So we set up this scientific advisory board led by Mark Kearney, who is a former national cardiovascular prevention lead. So we set up our own PPI group to guide us in terms of implementations. So we have a range of the cardiologists and GP involvement as well. So basically, what our work of developing this algorithm is not just the one simple tool. So we have a range of our program or work really starting from understanding the population, the incidence temporal trend, from understanding all the existing evidence in the country and also internationally. So we published a range of the protocol papers to guide us through the analysis and conducting the actual study. While we develop and validate our studies, we also try to extend that to the externally and collaborate with the international partners. And then we want to really clinically validate our algorithm in the community setting. So that is the whole pack of work around developing such algorithm and make it practically usable and implementable. So this is just a brief summary in terms of where I just discussed in terms of how we want to identify people with AF and how we develop this algorithm for prediction and and how we are implementing the clinical validations. The ultimate goal is trying to improve the early AF detection. So this is just some acknowledgement working with Professor Chris Gale and my PhD student Ramesh and some of the other cardiologists and colleagues from Japan and also Israel. So most of the study are funded by British Heart Foundation and also the BMS, so which is a pharmaceutical company which sponsored the clinical device for the ECG monitoring. And then we work with the TPP, which is the software provider for those general practice, and then we can implement this algorithm in their system to identify those higher and lower risk of patient. And I'm personally funded by the Bus Charity. So thank you all. I'm happy to take any questions.